Bronchitis is an inflammation of the lining of your bronchial tubes, which carry air to and from your lungs, and it's said to be chronic when there is persistent cough with sputum production for at least 3 months in at least 2 consecutive years in the absence of any other identifiable cause. Chronic bronchitis is one end of the spectrum of chronic obstructive pulmonary disease, with emphysema being the other, which is an anatomically defined condition characterized by destruction of the lung alveoli with airspace enlargement. They often coexist, probably because they share the same major risk factor: smoking. Other risk factors for chronic bronchitis include exposure to air pollutants like sulfur and nitrogen dioxide, exposure to dust and silica, as well as genetic factors like having a family history of chronic bronchitis. With COPD, the airways become obstructed and the lungs don't empty properly, and that leaves air trapped inside the lungs. For that reason, FVC, or forced vital capacity, is lower. Forced vital capacity is the total volume of air that can be forcibly expired after a maximal inspiration. The volume of air that can be forcibly expired in the first second is called FEV1. Likewise, the cumulative volume expired in 2 seconds is called FEV2, and the cumulative volume expired in 3 seconds is called FEV3. Normally, the entire vital capacity can be forcibly expired in 3 seconds, so there is no need for FEV4. FVC and FEV1 are useful indices of lung disease. Specifically, FEV1 to FVC ratio can be used to differentiate among diseases. For example, in a normal person, FEV1 to FVC ratio is approximately 0.8, meaning that 80% of the vital capacity can be expired in the first second of forced expiration. In a patient with an obstructive lung disease, both FVC and FEV1 are decreased, but FEV1 is decreased more than FVC is. Thus, FEV1 to FVC ratio is also decreased, which is typical of airway obstruction with increased resistance to expiratory airflow. Alright, so chronic bronchitis is a type of COPD that's diagnosed based on clinical symptoms, specifically coughing up a lot of mucus. But why does this happen? Let's first briefly review the lining of the airways. The trachea and bronchi are lined by ciliated pseudostratified columnar epithelium interspersed by goblet cells, which produce mucus. Going deeper past that layer, you've got the basement membrane and loose connective tissue called the lamina propria, which together with the epithelium makes up the mucosa. Beyond the mucosa, there is smooth muscle followed by more connective tissue, and together, these 2 layers make up the submucosa, and this is where the bronchial mucinous glands live. The earliest feature of chronic bronchitis is hypersecretion of mucus in the large airways, associated with hypertrophy of the submucosal glands in the trachea and bronchi. The basis for mucus hypersecretion is incompletely understood, but it appears to involve inflammatory mediators such as histamine and interleukin-13. With time, there is also a marked increase in goblet cells in small airways, small bronchi and bronchioles, leading to excessive mucus production that contributes to airway obstruction. It is thought that both the submucosal gland hypertrophy and the increase in goblet cells are protective reactions against tobacco smoke or other pollutants. The cardinal symptom of chronic bronchitis is a persistent cough productive of sparse sputum. For many years, no other respiratory functional impairment is present, but eventually dyspnea or shortness of breath develops. With the passage of time, and usually with continued smoking, other elements of COPD may appear, including hypercapnia, increased carbon dioxide in the blood, hypoxemia, low oxygen in the blood, and the increased carbon dioxide levels in the blood can get so bad that some people develop cyanosis, which is a blue discoloration of the skin, and this is why patients with chronic bronchitis are sometimes referred to as blue bloaters. Alright, so, in addition to those things, in the areas with decreased gas exchange, blood vessels undergo vasoconstriction in an attempt to shunt blood to an area with better exchange, which, if it's localized to one area of the lungs, that would work pretty well. But when a large proportion of the lungs aren't exchanging oxygen effectively, a large proportion of blood vessels start to clamp down. and this has the effect of increasing pulmonary vascular resistance, and to maintain pulmonary blood flow, the body responds by developing pulmonary hypertension. Over time, this increases the work needed by the right side of the heart to pump blood to the lungs, and eventually the right side enlarges, leading to right-sided heart failure, a process called cor pulmonale.
Do not forget to like the video and subscribe to our YouTube channel.